this moving skull that you can see that's all in pieces hooked together. You can realize that it's made of the many little pieces. Now we look from the front. Now terms like super and superior orbital mean the same thing. Super, you know, so when we say supraorbital foramen or superior orbital foramen, same thing. Infra or inferior, same thing. It's just an abbreviation of the same word. So don't get all messed up. Oh, it's not written that way. No. Some books refer to it as the inferior, some refer to it as the infra. And fissures will be inside the eye, the foramen on the outside. So the fissures sit inside the orbit. You're looking at your skulls today. And right here you have the optic canal. So everything comes through optic canal. The optic nerve, so you can see. You know, we got to get these nerves through to make your facial muscles work and bring sensation back to the brain and bring blood supply. Well, you have to have openings to create this to happen. And that's why you have all these holes and gullies inside your head. It's not just to test anatomy, students. You would think so, but no, it doesn't matter. You would think we did this on purpose. And the bone is the bottom part, and the perpendicular plate is the top part of your nasal septum. So the perpendicular plate comes from the ethmoid bone. So there's the middle nasal concha.
Test question.
What test question? Yeah, that's your test question. Well, the test question would be the four bones that create the septum. We'll worry about that when we do head, neck, and throat area. But it's right here, the bone. You can see the bone from the front, from the back. And all you can really see is the middle and inferior concha. You cannot see the superior concha unless you're actually looking at an ethmoid bone. It's tucked too far up, way up inside the head. Okay? So the other thing is to realize what makes up the organ of the eye. And we'll go to a bigger picture of this. Pretty. That kind of, look at that. Deviated septum and everything. So when the septum deviates, that's because you've damaged that perpendicular plane. They're going to break it and reset it. That's what they do by breaking it. Actually, use a chisel and smack it and break it and then reset it over. That's why the person's eyes are all black and blue. It's bruised. Orthopedic surgery almost looks like woodworking sometimes the way it's done.
When you break your nose, I thought that you broke the nasal bone.
Well, you can, but you also dislodge the danger part is not so much cracking the nasal bone as it is cracking the septum inside. Because what happens if this thing deviates way over, you can't breathe through that side anymore. And that creates problems, chronic infections. So it does create a lot of discomfort to a person. And they become a mouth breather versus breathing through their nose, snoring.
I've had my nose broken over 15 times.
That's why it looks good.
I know, they fixed it.
They fixed it. What it was, he had a big nose, so they hit it. It was in the way. He's a good sport. You can pick on him when he laughs. But just, you know, keep that in mind when you're looking at this stuff. Some things, you know, and you only look at what's on the handouts I give you, not things that aren't there. Okay, so if it's not there, don't worry about learning it. There's a lot more in here that we don't learn because we just don't have the time to. But we're teaching you the key important features that you can carry with you into physiology and into nursing. That's what we're trying to do, just lay a foundation. Mainly what you see from the other wall, the operator, you know, that's a good, real good foramen magnum. What do you think comes out from that? Spinal cord, because the brainstem's right above it. So your brainstem literally sits right here. So any bad whipping motion to the head does contuses the brainstem. That's why people have all these weird symptoms after being in a real bad whiplash, or they fall, you know, they're walking on ice and boom, the head whips. It really messes it up, because that thing controls all your automatic functions of your body. So just remember that. Then you have the condyles. Where do those things touch?
Those touch the axis.
Right. I mean, the atlas. The atlas.
Sorry, atlas. C1.
You got me. Ooh. Yeah. And that helps you do what? Say yes. No. So we have this girlfriend. Axis removed, so she can't sit going.
No. Her atlas was removed. She's Polish. All she does is that.
She's gonna beat you up. She has a nice Polish accent.
When I told her yesterday that you pointed out exactly what she screwed up, she flipped out. I see the American accent.
Because,
Yeah, it's fun.
because it's funny. When someone gets really irate over something, you don't forget it. And if you can purposely irate them and then bring them back down
It's
without
funny as hell.
killing them, it's funny as hell.
Hell, yeah.
Oh yeah, she is funny. Very smart, but funny. So, when you're looking, here's the cella turcica, or Turk salad. What is that? So, well, that's where the pituitary gland sits. So it's an important structure. But you're going to realize a lot of neurovascular problems that happen to the brain happen all in this region right here. And when we get to the vascular, you'll see that there's an area around here that's called the circle of Willis. And that's the major ring of blood vessels that sit around this cella turcica, this region here. And most strokes will happen somewhere in that region. Because the way it's designed, it's easy for them to get stuck in here. Hypertension, constantly pushing. Well, hemorrhages. So vascular type injuries such as hemorrhaging is much harder for them to treat and control than going in with a thrombolytic type. Okay. So, foramen magnum. Hypoglossal canal. When you look at those condyles underneath, you drill a hole through them. That would be the hypoglossal canal. And what nerve goes to hypoglossal canal? What'd you say? Hypoglossal. I was looking at you back there. Yeah.
That's your tongue.
That's your tongue nerve. Without that, your tongue don't move. So you won't be able to talk. The hypoglossal is pretty important. That's number 12. That's the last of the cranial nerves that you'll see. 2 is the, it's number 2. What's 2? Remember, it's 2.
Cranial nerves.
Is it optic?
Yeah, it's optic, good. Because number 1 is smell, olfactory. Those are becoming very shortly. It becomes quick. You know, before you know, we'll be whacking into, once we get through muscles, we'll be hitting the nervous system. There's kind of like 3, we spend a lot of time on nervous system.
No, please don't.
Well, she said you like to be challenged.
Mentally.
Mentally challenged.
More than I am one of the other.
Here's the ROS. Rotundum or valley spinosa. 1, 2, 3. They run in this 3 fashion, just like that. So there's a little hint. You know, it's like a hint to remember where my cerebral is and where my optic canal is. Because think of a saddle. So you sit down in the saddle and you put your 2 hands into the optic canals and hang on, and you tuck your feet into the cerebral to hold as your stirrups to stay on the saddle so you don't fall off. And that's an easy way of remembering. So your hands are going here, your buttocks here, and your feet here.
Another good way. Another good way. If you look on the left side instead of where it's all labeled on the right, your ROS and at the end of the L would be your last one.
Over here.
Yeah.
Yeah.
Oh yeah, it does make an L. You go
But also it doesn't do that though in reality, because you're not seeing, which could be blockading it, is the carotid canal. So that's why I want to move it together. And the reason I don't make the learn carotid canal, but in some skulls who have a true carotid canal on the insurface, you can see with its own foramen, or it'll canal underneath it and then come in through the cerebral. So 50% of the population just have hollow space there. So in other words, there's nothing going through your cerebral. And in some populations, the internal carotid is going through the cerebral to get in. So those are just anomalies that exist. But yeah. But what's the other thing you can find when you look in the skull? You've already looked in the hair. This thing might be way over here, and this one's here, and this one's here. They always don't run all the same in every skull. So in other words, if we took every one of us apart, we're not all totally the same inside. Things just shifted a little more left and right. So there's a variation all the time. So that's why when we do cats, we tell you, look at all of them. because they're all going to have variation. That's much of the muscles, as you will see when you get into the viscera. I had a cat one time when I opened it up. It had two
Parts?
no, it had two superior vena caves.
Damn.
But you only have one. One came down the other side and looped around the heart and came up into the right atrium, which is just unusual to see this thing. Because on dice, I said, that was this big blue vein I'm seeing on the right side, because there is none here. And I followed it back, and then you figured out it had an anomaly like that. So you get a lot of weird things happen, especially with vascular. Vascular has a million different anomalies, especially venous structure. No venous structure runs the same in any two people. Especially when you get to the deep veins, they're all different. That even in medicine, you don't bother learning them all because they're not the same. You just have to trace them. So just to be safe around it. But from the inside of the skull, be able to identify, just draw a big circle and label things. So back here would be the occipital. Temporal takes up this. The sphenoid is the big bat wing, and the ethmoid sits right in front of it, squished inside the frontal. So don't position it. Okay, so I might ask you, who moves its dead center in front of the sphenoid? And you'd say ethmoid. Right. What sits right behind lateral posterior to the sphenoid? Temporal. What foramen would you find foramen magnum in? I mean, what bone would you find foramen magnum? So those are questions that you can ask to see, do you really know you're an animal? Or do you think you know it?
Sure.
So those visual, those are good because they're so confusing. Sometimes they look so true and they're not. Kind of like politicians. It looks like someone honest what they're saying and they're lying through their teeth.
And I think you should make an effort to take those true and false questions off the top.
Oh, no, because see, she'll tell me she had to do it, so you should have. This, we have, oh, you're stretching. And that's what it would look like if you took. So you can see if you took the sphenoid out, this is what it looks like. It has all these little, most of the foramen sitting. Here's the cut through your head, which you don't have to know, because you don't teach it that. But to see like the nasal concha, the superior, they're way up high top. You just love to see the damn thing even on one that's cut off. Why do we have a crystal galley?
The cristigale is the anchor for the brain in front.
Exactly. It goes to middle, cerebral, foramen, right into it, so it doesn't shift. But the brain is held pretty damn good down at this area, with your brain standing in your spinal cord. In the front, there's nothing holding it in place. Especially if it's small, the brain will really bounce it up.
What, you don't have shit there at all?
A lot of ear space. Mandibular foramen's on the inside of the mandible. Mental foramen's on the outside. So right here's your mental. The mandibular is tucked way up in here. And then the nerve comes. So this is what they're aiming for when they go into the Novocaine needle to numb that nerve. Numb the mandibular nerve, so you know, you basically go gain the tooth out and go forward. And then they drill in the cavity. The bad thing when they use Novocaine, you don't realize how bad they're destroying you in there after it all wears off, and then the pain starts to, yeah, just the throbbing pain is so wonderful. Right, so it'd be the same nerve that comes out through both foramens, the mandibular division of the trigeminal, the sensation in the jaw. So even when they hit the inside, a lot of times it's not even out here. You can't, you know, you bite your lip and you don't really feel it. It's like, damn, you drink coffee and drools. Makes a good impression on a first date. You just had that. That you're drooling. She's like, oh, you're drooling over me. Here's your sinuses. Why do we have sinuses, people? To drain, to breathe, everything wrong. Filter? No. What's a sinus in general? This is space, it's a cavity. And so why do we have these cavities in our head? She was letting this go. I don't know how heavy your head would be with all that mass.
I got a big dome.
Right.
I mean, this right here is a freaking Foreman grill.
It was a good target in boxing. It was straight to block with his hand. You hurt your hand, you hurt your head.
Feet to fist. You get tired.
Keep punching your head, you'll get tired after a while. But the sinuses are there for a reason, the light of the skull. We ask you to think of drainage, but they're not supposed to be filled with any fluid mass. When that gets in there, there's a problem. You have infection. So in theory, there should be nothing in there. Okay? It should be an empty space. Some people have more sinus than they want inside the skull. We'll find that out in a couple of weeks. There's empty spaces going on in the head. In other words, you're being tested. Yes.
Okay, on the first practical, are we doing animal bones?
Animal bones?
Yeah.
Like the cat?
Yes.
No. Do you want to?
No.
I now Dr. J does that.
I now get to go home and...
No, Dr. J does that. You don't have to learn the cat bones. He makes you learn them. He'll put a cat skeleton on. I don't have to learn our skeleton. Here's the thing, we're not a comparative anatomy class. The cat's only used for certain tissues to give you an idea of what tissue really looks like and feels. You have the stomach actually look inside something that was once living. You know, you're going to go into careers that do it. I mean, like today I was looking at the website and common fractures and stuff. And some of them are so the bone is like hanging out, muscles hanging out here. It's like, I'm talking about making the class want to throw up and just look at it. But just remember, the sinuses are named after the bones where they are. So you have your maxillary, your ethmoid, sphenoid, frontal. Sphenoid's way back and deep. That's one that you get that pain under and behind your eye. Look at from the lateral view, where it's sitting. So they're pretty damn deep. The ethmoid's dead center. Like you'd be in here like pushing, oh, it's killing me. That's like, behind my eyes feel heavy. Well, that's because of that one's inflamed. The most common one first to get inflamed is this because of gravity. Yeah, that's your most common first one to get inflamed. And why is sinus infection so dangerous and should be treated? Bingo, they're next to the brain, the meninges are right near there. You know, left uncontrolled, untreated, a real bad strep in here could spread into the meninges. End up with meningitis, you get a chronic sinus infection. So they're not a good thing. Okay, so looking at this picture here, be comfortable with the bones around the eye socket, which make up. So primarily the floor of our, because this would go in this way, the floor of our eye socket primarily would be maxillary. The lateral wall, zygomatic bone. Medial wall, lacrimal, and most of it is ethmoid. Lacrimal is just that first front part. And then which one would this be right now?
Oh, that would be the nasal bone.
It's right there. It tells you what it is. Everybody's guessing everything but. It says nasal bone.
Oh, I know this was on the other side.
No, it's not on the other, yeah, it's on the other side of his head, yes. And what's this over here? Frontal. So the frontal's the roof, and what makes up the back, posterior wall of it? Sphenoid. Know that. Know descriptively how the bones kind of sit. Then you're not guessing, then you know.
And then the lecture test.
The lecture test will not destroy you.
You should just give them the diagram, honestly, but. Like,
That's too easy. That's too easy.
It's like, so you say like.
So when you read an X-ray report, you don't, a lot of times you don't, most of the time in practice, you don't see the X-ray. You just look at a visual report. So you have to be able to visualize.
I'm not going for that at all, but.
I think that is a proposal we need to
She's
make.
becoming an English teacher. She just wants to see what type of anatomy
So,
kids have to
Just
know.
so do
that
I
it
get a
is.
10-minute break from the test if I say your exam is giving me a sphenoid headache? Since it's correct.
You get an 8-minute.
Eight is fine. That's fine.
What's this big thing?
That's the mandible.
It
No,
looks like a stingray.
It's labeled again! It's labeled again!
I said hyoid.
Yeah, so it's kind of like having a friend Lloyd and saying, hi Lloyd, how you doing? Hyoid bone. The hyoid bone is the only free-floating bone in the body. Totally connected to muscle, ligament structure, no joint. It's a stabilizing bone, which we're going to see when we get into the head of the neck. stabilizes the tongue for movement, stabilizes the jaw to open, besides gravity opening it. It stabilizes the larynx, so when the glottis closes, you close it up to the epiglottis. So muscles all around are stabilizing in place depending on what you're using it for.
Oh, that's a bad part of it.
Or you'll have a muscle called hyoglossus. So when you think hyoid bone, hook to the tongue, pulls the tongue back in the mouth. Styloglossus, pharyngoglossus. You've got all these wonderful muscles that control your tongue. The extrinsic muscles. And if it's fractured, they know you were strangled.
Yeah, okay.
So you watch CSI.
I do like
See, when you watch CSI and NCIS, you say, wow, look at this. I know now. Here's my world. You know, we did the ligation on my hand, crushed them to death because it's crunchy. So now that we finally get out of the skull and we go to the vertebral column, which is made up of cervical, thoracic, lumbar, sacral, coccyx. Okay? It's designed to do what? Protect the spinal cord. And of course, hold the body erect and everything that attaches to us. But it does have a big role in the spinal cord being protected. Because it has a vertebral foramen in the middle, which does what?
Allows your spinal cord to go.
Your spinal cord goes forward. And since we got it this way here, what are these holes right here known as?
Those are the
intervertebral foramen. How are those created? Well, they're created by the vertebrae above, and the vertebrae below hook up, and they make a hole. And we cut a hole between two vertebrae, so instead of saying we're going to hole between two vertebrae, it sounds like we're somewhat intelligent, we say intervertebral foramen, because foramen means hole, inter in between the vertebrae, so intervertebral foramen. What comes out of that? Spinal nerve.
Doesn't it? Oh, you mean so this is the hole in the middle, not the
Yeah, it's on the sides, not the sides.
the side?
That's a lot of vehicles.
I thought most
Well,
of them were afraid of the
made it in
middle.
the snow. You don't wear a jacket in the snow? Oh my God. That's a lot. No hat either? Grape soap.
I'm from Florida, I'm not used to snow.
And you what?
Oh, okay.
Cover like 7 layers.
I know, we're from Florida. We're from Rhode Island, we got like,
It's a hat.
that's it, it's a hat.
Which nerves come out of that?
Or your spinal nerves.
Spinal nerves.
Like the brachial plexus, sacral plexus.
On the sides, huh?
On the side. So it's lateral,
Let's
right?
not get ahead of each other.
See? Because this is the front, that's the back. This would be a frontal view, right? So this would be a lateral view. So the nerve would come out, go around. The nerve would come out from here and go down into the leg. So that's like posterior lateral, where it'll sit right behind the body. So that's why you get, herniated disc rolls right into that, which we'll see in the end. So this is just to pick up those. So the other vertebrae, there it is again, nice big.
So does that mean herniated disc if I look now?
Right, because we can go into it, exactly. Like that one's doing, but I don't want that picture. This is what I want. Okay, so here's the vertebral foramen. I'll go back to this. But here's the vertebral foramen. So I told you in lab yesterday, that most vertebrae from C3 to L5 have this common characteristic of pots on it. What happened to atlas? Why can't we use that as a description here?
Because it's one type of bone.
And it has no,
Distinguishing characteristics.
like a,
There's no
Yeah,
body.
there's no body. It's like you have nobody that has no body.
Oh, shots fired. Danger close.
Right? No body. It's just a ring. Now, if you look at C2 from underneath the axis, it kind of looks normal, but when you look at the top, it's got a big thing sticking up called, no, it's a dent. It's not that. It's a dent, okay?
And you set yourself up.
And that's for pivoting. So when we look at C3 all the way down to L5, they kind of have similar characteristics, such as a body, and they all have this opening in them called the vertebral foramen, which we said spinal cord goes through. This is what makes up the spinal column, is that. Then as we look at it, we have sticking out straight back, the spinous process sticking off to the side, the transverse process. Well, when you go from the body to this region here where the transverse process is, this area is known as the pedicle. And the area from the transverse process to the uniting of the spinous process is the lamina. That's what they cut when they do laminectomy. They would cut this way here and lift it up to get in there. Okay?
So she got the superior articular facet wrong.
No. She got this one. The costal facet she got the transverse costal facet wrong. She called it the transverse process. And that was
From what to what is called the limb again?
from the transverse process region
Yep.
to the spinous process. So this bony area. And this is usually known as the vertebral arch. Okay, so it goes the neural arch, but vertebral arch. Because it makes a true arch. A nice circle. Here, though, we have this other thing called articular process and facets. What's the difference between a facet and a process?
Facet is flat.
And smooth, designed for.
Wait
there. So touching means articulation, so let's use anatomical terms. So it's designed for articulating to another bone. Okay?
Yeah.
She was brighter than you. She was brighter than you. So she learned it better. And then you have, it's nice that the class was small like this all the time. Then you have the process. The process is a projection to hold that facet. Okay? So a process means a projection that sticks off the bone. There's a decent size to just what they call a process. It sticks out a little bit than the tuber. So there's different ways of describing these bumps and crannies on the bone. And that's why it is uploaded on your blackboard on the lab outlines. There's also a thing with these anatomical terms using these descriptions.
And what is it?
They're also in the lab. So
What does the facet do again? Like the difference?
it's a smooth surface, smooth flat surface usually for articulating, to touch another bone. So on the vertebrae we have on the top, superior ones, on the bottom, inferior ones. Okay? And those sit on the articular processes, or in some books refer to it as the articular pillar. So that's this region right here. Okay? And if you look out from the side, you see them sticking up and sticking down. They're supposed to. Okay? If you look at the side view, which you will in a second, you'll see that. Alright? So they have all these characteristics. This vertebrae, I'm going to jump right into the thoracic vertebrae. Why? Because this happens to be a thoracic vertebrae. How do I know that? Because of this and this. And what are these for? Well, these here are articulations for ribs. And they would be known, this one back here, because it's on the transverse process, would be called transverse costal facet. And I'll show you a picture of the thoracic, but I don't name it for you, so don't get all nervous. And this one's on the body, and this would be known as costal facet. Okay? So you have a superior and inferior costal facet. So if that's a superior, I think that's going to be a superior costal facet. And on the other side, you have an inferior costal facet. So when a rib comes in, let's show you how a rib will come into a thoracic vertebrae. This. It comes in, the tubercle of the rib touches that, the head of the rib touches here. It touches three parts of the spine when it comes in of the vertebrae. Because not only is it touching, it's touching the superior aspect of one, it's touching the inferior aspect of the one above. So look at the skeletons today. Pay attention to that if you get a chance to. Unless Dr. Royal didn't get here. Then you want. Then you're lucky. Well, not lucky, you're just too responsible for it on the practical. He doesn't care because we have lab yeah, I don't care. But there you go. So there, see, you're seeing it in. Transverse costal facet for tubercle of rib. It's telling you. Right? Superior costal facet for head of rib. That's stuff you should know. Because I may ask you, what's the tubercle of the rib touch? What's the head of the rib touch? No, that's just remnant. That's for you. That's remnant of what.
Oh, we evolved from, but like,
Yeah, exactly.
well, we evolved from
Some do.
monkeys, apes.
Chimpanzee, right, but it's just the genetic order of,
Were we ever monkeys?
I don't know if we were monkeys, but we could have been. We could have used tails when we were cavemen, who knows? I wasn't the first person back there to design it.
We should do like some animal anatomy. How do tails work? In like prehensile tails? and
Well, you would if
back
you did
legs?
the see, that's why you should take the pattern of anatomy.
I
because
would
then you
love
are
to do
right.
that. I have to take human.
Right, like a pattern of anatomy would give you that insight of why.
Just trying to make it hurt.
Yes, it's trying to make it how.
Did you, were you trying to scare your last semester into not taking this class by saying they were going to do monkeys this semester?
They were doing monkeys.
Monkeys.
I said they were doing monkeys.
Yeah.
Monkeys with prehensile tails are so cool. That means their spine extends.
Before
It's
they,
like a hand.
you know, when there was shortage of cadavers, they did rhesus monkeys, they dissected them because it has a similarity to our anatomy. So they would use, you know, some med schools would use that.
It's almost that.
Yeah. What would they do to them in Africa? Mash their heads and the brain and that's terrible. It's like a delicacy. So let's go back up now. Let's finish up with the thoracic. Let's do our thoracic first to be done. So there's certain characteristics on the thoracic vertebrae. First of all, we have 1 through 12. There's 12 of them. They have facets for rib. We just went over that. So you have transverse costal facet, inferior costal facet, and you have a superior costal facet. The spinous process is huge. So the thing, when you look at it straight at you, looks like the face of a giraffe. And here's a process sticking up, see, with a articular facet out. But they stick it up, so it's a process. And now that we have a smooth surface, we have a facet on the process. That's all that's telling you when you look at that. And the key is their articular facets run in a coronal fashion, a coronal plane. Like, yesterday's afternoon lecture has become pretty cool because there was a student that was waiting out there for class. You know, we'll cover scoliosis and all that in here today. We talked about when you would race and when you would. Well, he had one, they had to put a rod in it. So he came in, he had his iPhone, he took the picture, passed it on the class of what it looks like the rod bolted in. And they bolted it from C6 all the way down to L2. Damn. So he has no movement other than 3 seconds below and 4 above.
Yeah, I was gonna say it's totally rigid, right?
It's totally big. Oh yeah.
Yeah, he slips. He's not going to.
And it was pretty amazing, you know, that we were talking about it. And then he pulled his shirt off so you could see the scar on his back that went from here to here.
Can you see the difference? Like, can you see it, like, in his back at all?
No, because it's deep into the bone.
Huh. How do they put it under the spine like that? Is it like
They do a total laminectomy, remove all the lamina out of the way, and they put it in, and then they fill back over it with excess lamina and bone chips, and then they screw it and bolt it, and the bolts, as they're bolting, it starts pulling in this type of fashion to take that spine and pull it straight. And then they lock it in place, and they brace you, and then it heals out.
Is his body perfectly straight?
He's straight
Back
now, yeah.
arch?
Oh, no, his back is, from looking at him from the external clothes, I looks normal. But, you know, what has he lost? He lost some of his thoracic curvature a little bit because it's more flat. And his neck, cervical spine is a little more flattened. The lumbar spine is probably a little more extenuated on him. So what will happen is those few movable segments will wear out at a much faster pace than they will on you, because that's the only thing that moves. And he can't bend like this anymore.
Is that something?
He's lost that, so because he doesn't have lumbar flexion, so he kind of has to do this to bend. Shows he can't move anymore.
They can do that all in one surgery though, where they can bolt
All
that in
one,
place
the
it and
surgery
then
was 9
straighten
hours,
it.
9 hours long.
Because I imagine
He was
like,
under for 9 hours,
that's crazy.
and the pain was excruciating after, the recovery coming out of it. And they had 1 week of physical therapy and off he went. That's all insurance companies pay for. But they're going to see that when we get into it, so let's hold those questions today. If you have questions, just don't forget. I want to move along so we get you people going. Okay? So let's jump up to the cervical spine now. In the cervical spine, we have these weird shaped vertebrae. First of all, we have the first one, which is atlas. And on a practical, you're going to write it just like that. Because you just write that, it don't count.
Even though it's right.
Even though it's right, it doesn't count. It's not telling me what it is. It's an atlas.
So can we just say atlas and not C1?
Yeah, you could. You can get away with atlas without C1. But you put C1 with no atlas, wrong. See how mean I am? It's just a ring structure. It's just a ring structure. And we know we're looking from the underneath that says inferior, but because of the shape, it's a flat, rounded set, so it can lead on to C2, which is your axis, because here, looking down on it. So why does it look like that? Because those are designed to hook to the condyles that are on the occiput of the skull. So they're shaped that way. So you can do this. Move your head back and forth. There you go. That's why it's shaped that way. And notice there's no spinous process either. It's got a posterior tubercle. There's no spinous process because the tubercle is smaller than the process. It has transverse process. And it also has this other key thing that all cervical vertebrae have, that you know you're looking at one, transverse foramen, a hole in the transverse process. What goes through the transverse foramen? Just an artery. What is it?
We're going to go with carotid.
Don't listen to him, he gave you the wrong answer. What would you go with there?
I don't know, I'm trying to think. It's an artery?
It's an artery, which one?
Cranial.
Carotid?
What?
Carotid?
No, he said that. That's
Oh,
it.
I'm sorry.
And I made
All
fun
right.
of him for saying.
I got that wrong on the tip exam.
So she got the excuse over here, went out of the hand, we go, right out of the So what is it? You're like, leave me alone, that's why I'm here again, because I didn't get it. How about vertebral artery? Does that ring a little bell yet?
Yes.
No.
It does with her. Vertebral artery.
Vertebral?
Vertebral, not vertebrae, vertebral artery. It comes off the subclavian and goes posterior, superior, up from C7 all the way. That's how you feed the posterior part of your brain, and the brainstem comes off that. The vertebral comes together, forms the basilar into the foramen magnum. It goes to the posterior aspect of circularis, makes the posterior cerebral arteries. There you go. That's how it works. So, people that have real severe degenerative diseases in their neck, arthritis so bad, they can have actual spur formation growing right towards that vertebral artery. Head extends too much and a slip and fall or something, severs the artery. They go home feeling a little lightheaded because they think they fell down.
Yeah, no,
You're all right. They go to sleep, they don't wake up. They wake up dead. They wake up dead. Wake up, you're dead. What a joke that is. I went to sleep and I woke up dead. What the hell?
Wait, is that why a lot of old people like die in their sleep?
No, they die in their sleep mostly because of usually heart problems, cardiac situation.
I mean, when you have like some hemorrhage or come out, like you have some swelling and stuff like that,
Not
right?
necessarily.
Really? From that amount of blood loss in your
It's a
body?
small
I
artery.
mean,
It's a small artery and it's going to bleed internally into the spinal cord from top. And what's it doing? It's not letting blood go to the brain. So all the main centers that control respiration and heart, magnetic supply, they shut down. So they're the first centers to shut down. That's why the person dies.
I guess it sounds kind of peaceful.
It would be a peaceful way to go. You know, if we bleed you out, you don't suffer.
Better than drinking Drano.
You go, you're right, better than drinking Drano, sulfuric acid, but it's like, you know, but you would go peacefully, because you just fall asleep.
Can they catch that and repair it? Or can you sew it on?
If it's early, yeah. So it could even happen like an older woman at the hairdresser, just extending too much, having their hair washed, could induce a stroke. You can impinge the artery enough to throw a clot, and that could do it. So, you know, so there are tests that you do to see if the person, so they, you know, you take the person's head, put it back on the right, arch it back, a little pressure, they start getting lightheaded, boom. That's contraindication. You can't do manipulation to that person's neck. You can't take it. You know, so there's orthopedic tests you do to see if the person does have this. And usually when you take 50 or older crowd, you get them to try this on. Or they can have plaquing. So that's the other nasty thing. Those plaques are going to eventually break. One breaks off, goes to the brain, there's a stroke. So it is, you know, a significant situation. The other type of injuries you can have to this vertebrae, from front or back, is what they call a burst fracture. So the person jumps into a swimming pool and their head hits and it jams into the neck. The rib just explodes, boom, called a burst fracture. Very unstable, and the first thing the person would have is like a headache and like lightheaded from banging their head. They have neck stiffness. That's the only thing they present with. Their neck is really stiff and I feel a little wobbly. Within 3 hours, they'll go totally unconscious. If the swelling and edema starts building up, it closes off the spinal cord. So that person, they usually will tell them that we're going to have to push, we're going to do surgery on you, we're going to put you into a medical coma. We have to. And we're going to slowly bring you out in a few days to see if your nervous system reacts. Because they don't know. They don't know how much spinal damage is going to happen. Even though they load you up with, steroids and stuff to keep the swelling down, it's going to happen. And if you watch any of these medical shows that are on, and someone has anything like this, they'll be talking to the person. In about another half hour, you're going to go unconscious on your own. So we're going to induce it so you don't suffer. And they'll trade tubing and everything and put them on. And then they do the surgery. And they go and reclamp everything back, put them in halo traction for 6 months. But doesn't mean it's going to respond. This will heal, but you don't know how much damage you're going to have to the spinal cord and brainstem at this point. Because you don't know how much damage the swelling and edema is going to do. And there's only so much they can do to prevent. Hopefully, in some cases, within a week, they know the person's going to be normal. When we look at this guy, this has a bump sticking up called the dents. And in the lab, what did I say the other name of the dents is for my lab? Odontoid process. Odontoid process. The name odontoid process. It's another name for dents. So if you see that on a test, let's say it wasn't told to you, odontoid process. See, this is why you need to come to lecture and not just think you can study at home on your own. Because I throw things in here that you're not going to get if you don't come less.
The dent would be correct with it?
But that's right on the name of this dent. Is it true that C2, the atlas, has a process called the odontoid process? True or false? Yes, but most people want to say false because we never knew that. That's another name for the dents.
Sneaky bastard, any true or false? Tricks us with
It's another name for it.
dents equals, what was it again? Oh,
Equals dents.
odontoid process.
So it's like, think of an Irish name, but then the way it begins with odontoid. Oh, odontoid. Like odontoid. Or McDonald's, right? But an old for McDonald's.
If you jump to a patient, no, boy.
So there you go. Watch out, you'll hurt your oil. Okay. So the dent is there for pivoting. That's why it pivots. It's a pivot joint. When we do joints next week, I think we'll see that's a pivot joint. Okay. Then you'll see when C1 hooks here, there's a ligament that holds this like this. Not the one, there's one back here, and there's one that holds it together too. And people with rheumatoid, believe it or not, that rheumatoid arthritis attacks that ligament. And C1 and C2 become very unstable going on. That when the head will lean forward, instead of the space only opening up 1 to 3 millimeters, it'll like gap. That's another dangerous situation. That person can be very careful. Severe whiplash, slipping forward, the head really whips will kill them. They'll die because they'll sever the spinal cord. So that goes to bring us to another type fracture that's very unstable. That was a burst fracture. The other type would be hangman's fracture. When you hang someone, you don't choke them to death. You're not straining. You break the neck. And how you break the neck is they place the knot right at the transverse process of C1. So when the body falls, the knot pulls across, not only tractions, and the knot takes C1 and shoves it right across the spine, snapping off the dents and snapping the spinal cord at the level of C1 in the brainstem. So the person dies instantly, there's no suffering. So they're pretty much dead before they hit. They're dead. So not supposed to be hanging and choking to death. And in Nazi camps, when Hitler would hang like the young Jewish kids to get rid of them, they were too light, so they'd have to grab their legs and yank them at the same time as they were pulling to finish breaking their necks. I mean, it was cool. Take you out in the shower so the water come out, gas came out. He was a tough person. You know, he really wanted the genocide. He tried. Like dumb things. Believe it or not, because of all the torturing they did, is how we learned so much about the nervous system. Because they would dissect people alive, just to see the nerve and see the reaction.
There's a lot of medical research that
A lot of medical research that came out of the Holocaust, which is awful, but we also learned a lot from.
Yeah, it's like life-saving stuff.
Life-saving stuff today.
Yeah.
So if you're studying it, a lot of your neuroscience came from World War II. That's why they learned so much about pain reception and brain and things that would destroy it. And it's scary, but they did. So you can see this one does have a spinous process, but the body is kind of weird shaped because you got that dent on the odontoid. Now we go into the recto cervical spine. You have C3 to C7. They have, all of them have what? Transverse foramen. You're not seeing it here, but they all have transverse foramen because the vertebral artery goes through it. They all have this weird shaped spine that's called the bifid spinous process. And that's for the supraspinous lesion to really block in as it comes up to hook into the EOP of the brain, the skull. And what they also have too is their articular facets run in a oblique plane. And the reason oblique is because the greatest amount of rotation takes place in your neck area. So they run obliquely. In the thoracic spine, we said they run coronal, so the greatest amount of lateral bending takes place. And that person will have the rod put in, you can't lateral bend either because that rod is solid. And some of them snapped.
Why would they put joints in the rod?
They don't want any movement there because they know it'll go back to the form. That's the reason why.
Could cause additional damage.
It would.
Alright, so they
Yes,
don't love those, they just call it, just the science process, or the science process, or?
No, just letting you know that's a characteristic it has that when you look at it, you can recognize it.
Oh,
So bifid spinous, yeah, that's, this one's nervous now, so you made me get nervous, see, you asked the question. So that's just, you have 7 cervical, 12 thoracic, so where do we go? Lumbar, yay. The lumbar, it's easy, because it's just big bull nose spinous, like a big nose anchoring off there. Big strong body to take on a lot of weight. That's kind of why you shouldn't put your body weight and spin on your head, because it's not designed to take weight. You want to, they really don't do a good job of weight bearing. If you stand the wrong way while you're doing it, you could snap your neck.
Well, it's full of air and really,
You know, so. But the other thing is with their, again, we have an articular process with an articular facet. Their facets will run in a sagittal plane. And the reason why is the greatest amount of flexion and extension takes place in the lumbar spine. So rotation in the cervical, side bending in the thoracic, flexion extension in the lumbar spine. And they all have to move on one another. That's what people don't realize. They all have movement on one another. And when you look at the way a spine is set up, these are the most common sites for degeneration. And right here, see 5, 6, the most common sites. Those are the first vertebrae you see wear out. Just like the medial knee. First area you see wear out in a person. That's going to be arthritic prone. So certain areas will wear faster because more weight bearing going through. So, and then we have segments in the spine, as we call them, transition segments. Meaning we're going from one curve design to another. One curve design to another. When you see, if you're looking for compression fractures, the biggest area to see them is T12L1. Is the most common site. Mid-dorsal on the anterior aspects. So there's certain areas you look for trauma when you suspect what might happen. By the type of trauma that happened to a person, you kind of know what to look for when you look in certain regions, what you should be seeing. Because of just the way it's shaped. How's it carrying weight? So weight will go through more here than there. Okay, as it's going through, more weight's coming through this aspect. More weight starts pushing through the posterior aspect. And because of that, see this thing here? This is known as the Scotty dog. There's his ear with his nose, his neck, his front paw. And if you look at an x-ray and you see your Scotty dog has a collar on it, meaning it's a loosened collar, and you should be able to see anything, it's fractured. And that's a true terminology used in reality. The Scotty dog has there's a lucency in the Scotty dog's neck, and we call it posterior articularis, it's the fracture. But what happens, this fracture, so you fractured that pedicle, that part where the bones meet, the body meets that ring, you fracture it. This is very common in young teenage cheerleaders and gymnasts. Why? Because they're always jumping and landing like this. Boom! Make their mount, I stay back and they mount. All the weight bearing instead of going to the body is going through here, and finally it snaps. And the person has a lot of pain, and it'll heal if you take them out of it for a while, because it's still young enough to heal. But what will happen if it doesn't? The other side may fracture, and then this starts slipping away from that. And you'll take an x-ray, and you'll actually see the body of L5 hanging off the sacrum like it's ready to tumble into a very unstable little back. Now, you can have that genetically. If it's genetic, you don't worry about it. Because remember, that's a growth cycle, so that might not grow on some people, might not fuse. So there's a lot that you look at. When we look at the sacrum, 5 fused segments. So altogether, and the coccyx are 4 fused, so this is a joint right here. Altogether, there's 24 movable spots in the spine. You get like 24 movable segments. Everything else is not. And all you need to know is anterior sacral foramen, posterior sacral foramen. There's no such thing as a posterior sacral facet. That's an error on your lab notes that you have. It should say foramen, not facet. Okay? It's not on here. It's on your handout for lab. I finally went in this morning and corrected it. It's too late. It's already up on the blackboard. You know what? Everybody's going to download it. The next semester.
Would you accept posterior sacral foramen?
No. Yes, that's what it is. I said facet. There's no such thing as a posterior sacral facet. It's wrong on your lab handout.
But you would take posterior sacral foramen?
Yeah.
Because if you study the words,
Instead of foramen now?
Yeah. Cool. Yeah, don't make it difference. Let's put foramen there.
Posterior -1.
Yeah. So there you go. So that's why your spine area. And we go on. So next I think we can go to the disc. It's up here. Let's look at the disc. The disc is a shock absorber. It's made of fibrocartilage. Remember that? Those little red cartilage they showed in the picture. So look, you find this type of cartilage material, intervertebral disc, pubic symphysis, menisci of the knee. Well, this is a shock absorber. And the middle portion, this is one that's being, the middle portion of it is made of a gel. There's a little thing. You were a gel, what represent
So we need a fucking chair.
Nucleus pulposus is the jelly liquid portion in the middle. I guess no fish left there.
I heard him fucking yelling at shit fucking about 20 minutes ago.
And the jelly portion in the middle, we have this annular fibrous ring on the outside known as the annulus fibrosus. So there's 2 parts. So it's like a jelly donut. When you squish it, the jelly pushes out. Or we squish this too hard, or we shear it. The liquid portion, how would you shear it? By carrying something heavy, and as you're lifting it, you go, ooh, and that's it. Or you sneeze, but you're headed in the wrong direction, and you'll blow a disc in your neck.
Threw my back out 3 weeks ago, so I was bent over and sneezed.
Yeah.
Fuck around with it.
That's right. So you're going to stay laying down when you sneeze.
So
Does that have to sneeze? Just lay
So
down.
that's a shock absorber.
It is.
Are those in the hips too?
No.
Damn.
So they wear out. But here, these wear out too, they can generate. But the point is, when the force comes down on it, that liquid portion pushes up against those rings, and those rings hold it in, it can't push anymore, and it pushes. So every time you walk and stuff, these things are cushioning you. That's why they're there. And that's why through life, you can lose up to 1 inch of height, because every one of these start to degenerate or desiccate or dehydrate as time goes on. and all your joints do. So you can lose, you know, so if you're 6 feet, you might be 5'11" by the time you're 7. So you will lose a little height. So if you're before 10, you're really going to be short and you're
They're gonna call you fucking
early. And that song that we around from the 70s, short people have no short people have no use for living. There was a big hit, made the top 10. And I was in college. Here's an MRI of the spine showing you a herniated disc. And, you know, this is an L5-S1, so we're hitting the L5 nerve, so the person would have a lot of pain wrapping into here. You know, the pain could be posterior calf, maybe if we're hitting S1 and 2, if it's dropping down inside. But it's significant. It is a spinal cord right here. It's into it.
Does that do the sciatic nerve?
It is a sciatic nerve. It's hitting one of the branches. This has a bulge here. So this bulge is a very normal variance. If you MRI this class, I guarantee 90% of you have this bulge. If you're in your 20s, you know, I'm sure you have a lot of, because of what you did. You know, the wear on your body. But they're normal variants, so you don't look at this and, oh, that's why you have pain. No. You're having pain usually because of something back here in the pain sensitive area. You don't really have nerve endings around the disc area to sense pain. Pain only will be sensed if it gets big enough to push into a spinal nerve or the spinal cord. But when we talk about the facets, which are back here, each facet has its own individual nerve letting you know proprioception of it because it's a diaphragmal joint known as the sinovertebral nerve. And you get inflammation or facet jamming, that's a big problem. So people really suffer with back pain. And those are very easy to fix. But disc is a very long, drawn-out process. One like this would need surgery. You would not be able to fix this with surgery. You might get a little under control, but as soon as that person moves the wrong way again, boom. What you want it to do, hopefully, is fragment right off. It'll calcify, and then the body reabsorb it. So you really like when the disc becomes a hardened disc and calcifies, because the body reabsorbs calcium. It'll reabsorb it back.
Then you have no disc.
No, I'm just talking about the liquid portion.
Oh.
Can they make synthetic discs so they ever?
They do, but they haven't been successful.
No. Can't make a little pouch?
They've tried many. What they used to use years ago was meat tenderizer. You go in there and inject it, and it would blow out, it would disintegrate that disc around doing surgery. It was big in Canada back in the mid-80s. But they found a lot of people had anaphylactic shock. So there was, you know, so I cured the disc, but they died on the table because they had anaphylactic shock. Can't have everything, people. If you fix that, they should won't have back pain in your next life.
I like what we're doing here. Let's do that.
So now let's go here. And we're going to talk about 3 major curves. Your book uses these terms wrong because they're supposed to exist in you, a lordotic and a kyphotic curve. They have to. When you look at the person from the side, the spine from the side is not flat. It has bending in it, it's supposed to. So we'll write this in green. So when we talk about the kyphosis first, that unhappy old lady in the middle there, the kyphosis means a forward bending curve, right?
Yes, it does.
And that's what it stands for. This is a primary curve. You're born with this. If you look at the way the fetus or the baby comes out, it's shaped like this, the spine. So you do an X-ray on it.
Is that a sperm?
This? No, it's not a sperm.
I like it. Oh, yeah, the nose makes
If
it.
that came out of something, that chick would not stop screaming.
So, well, there's the eye, the nose, the mouth, the smile, and so there it is. Usually a baby screaming, so it has a mouth like this.
Yeah.
But we're trying to see how the curve goes straight. So it's a forward bending curve. As the baby develops, it's going to develop a secondary curve. First in the cervical spine, second in the lumbar spine. So when you get to lordosis, that's a backward bending curve.
Bless you. Jenks, kill me some.
Okay? So if you think about the baby when it's about 3 or 4 months old, it sneezes. No, it's on its own fours and it picks its head up. It starts bobbling its head. As it starts to bobble its head, it starts to develop a curve in the cervical region. The kyphotic curve will always stay in the thoracic spine. So this would be the cervical area, is the thoracic area. What happens around 9, 10 months? Starts to stand up, hold on to things, starts to walk. Now we start to develop a secondary curve in the lumbar spine, and then here would be a sacrum. So there's the lumbar spine. So cervical and lumbar curves develop secondary after the baby's born, in all of us. They're not born with it. So what they're doing here with this is they're showing you pathologies of the curve. This woman should be called a hyperkyphotic curve, meaning an increase. Look at this. She got that nice down just coming out, like old people getting this.
Holy shit, it's Quasimodo.
Her ear should be falling on the anterior third of her shoulder. It's missing it. It's anterior to it. That's not a good thing. So you're getting an extenuation of the cervical curve in here, and probably flattening at the top, and she's standing like this. Who knows? She could have been a secretary her whole life, or just did nothing for type activity, just sat and did whatever she did, never put her body into extension. The biggest pathology of most people, and most people can't do this, it tells them to put your heels right against the wall, stand there, now take your chin and try to drive it straight through your head, and you push back, push back. Most people cannot touch their head to the wall without significant pain. What you're doing is opening up those facets, they can't extend them. Nobody bothers extending their body. Just by taking your head, pushing back, take your shoulders, retract up, pull them back, take your hand, push straight back. That's opening all these curves, pushing them back, working them. Take an exercise where you're bringing the shoulders back and so forth. So what's happening in this case, the muscles of the front have overtaken the posterior muscles and it's just yanking that curve forward. In her case, it's too late to fix it. So she probably had normal posture just like you guys do right now. But how would it like to be when you're like 45, 50, you have a neck like that.
I don't have breast line at mid.
And your breast line at that age won't look good. It'll be down around your belly button. There it is. Yes.
Does running, like running every day for a long period of time, does that do anything, like the gravitational?
Oh, it helps you, but it doesn't do wonders to your knees and ankles.
No, but I'm saying, is it bad?
Is it bad?
For your back, no.
Running is not like an ideal form of exercise.
It's not. We're not designed to do that. She's right. I mean, to run a couple, if you just walk a fast pace, it has the same cardiac effect on you as running in mine. So you're better off walking a fast-paced walk for 3 miles than you are running 2 miles. And the reason I say that, you're not damaging your joints. Eventually, runners do blow their knees out. I got a sister-in-law whose head sticking in this wall. She already had 3 knee surgeries, still runs in and out. And I said, people are going to have a knee replacement by the time you're 45. It's insane. It'll wear the joint out. You're overusing it, you're overtaxing it, you're constantly. If you're running on good tracks or good shoes, it helps because you're running on a cushioned environment. But
You're supposed to replace your shoes like every 3 months,
Right,
so like every
people
couple hundred miles, nice like
the people
yeah,
do
nobody
that.
does.
That's too damn expensive. The shoes are
Yeah,
not cheap.
exactly.
You're going to be blowing $150 on these sneakers, and they still look good, and you're throwing them away for new ones. And most people don't, unless true professional runners, they do. But in general, you don't have to do that to stay in shape. You're better off doing core exercises, upper back exercises, and walk. 3 to 4 times a week. Just do it 3 to 4 times a week, 45 minutes a day, 4 times a week. It's all you need to do to keep your body healthy and in shape. You don't have to be a gym rat. The gym rats to become like on the beach walking around. Look at this guy. Look at this girl. Have you seen my people? But I mean, do you want to see what a girl that's got more muscles than you? Not really. Oh, you?
Oh, yeah.
Hell yeah, he does.
I would break you.
I would break you all back if you move wrong.
Oh shit. Wrong situation.
Now, take this case. She's happy. Right? She's happy. And she's pregnant, right? Or she drinks too much beer, one or the other. So what's happening?
She's very close.
Now you got this case here where her head would be here. That's that first one we're showing you. Her head's forward to the shoulder line and her back is doing this, okay? And we have this taking place in her neck. So we're extenuating that and that in that older woman. The younger girl, her neck would be somewhat flattening down a bit, and this posture here is extenuating in this way because of the baby. This should be short-term lived if she don't do any type exercising after. No, her muscles will stay weak in the abdomen and she'll develop a posture like this, known as a sway back. And her spine is curving way in. What happens? Well, think of those foramen back there, and we're arching those vertebrae more and more and more. Well, the foramen opening is getting smaller and smaller and smaller for the largest nerve in the body. So you create a chronic sciatica in these people if you don't fix that posture. So someone that has the big beer belly and everything else, they're standing like this.
Yeah, carry your kid proper. How about it?
So they walk like this, and they walk in pain. Once we get to the nervous system, stop watching people walk and move. You can tell when somebody's in pain, just the way they're throwing their arm. Their arms, they don't have normal rhythm as the body's moving. It's off. So something's going on. Take this stuff up on people. Huh?
Get arrested for stalking. Just don't walk with me.
Well, you don't have to make it obvious.
Oh, got it. Sneaker.
So
I mean, one time one of my students was walking in front of me. I said, man, you must have back pain. You're really tight on your right. I said, you're turning your foot out to the right, the way you're throwing it, and you're protecting it. Stop watching me when I walk. Is what I'm saying. I said, well, you don't have back pain. I said, yeah, you can see that. But, you know, someone with true back pain will be hunched over. They'll be in a patagic gait, the leg bent on that side. Why? Because they can't extend the leg. Because you stretch the nerve, it hurts. But there we go. That, in this case of this picture, is showing you a pathology. It's not normal. Okay, it's not normal. The one that's always a pathology is the one that's to the left, the scoliosis. This is never good. This doesn't belong. Now, first of all, nobody's totally straight like this, looking straight at him. There's no such thing. Gravity's pulling on the spine and wears it down a bit. But this is what, you know, but you're not supposed to be like this. You're going to stand there walking like this. You know, like the ego special. You know, special. And what's happening here is there's a couple of things you have. Genetically, the bones, the way they're shaping themselves, or there's such muscle ligament imbalance on each side you get in this. The younger it happens, the worse it will progress. It's known as idiopathic scoliosis. Unknown etiology just happens. Okay? But this is a decent progression here. This person would have razorback deformity. So you take scoliosis, which you just need to know what their pathologies. But you take and that's a side bending curve. But you take a scoliosis